Thank you, respected faculty, for an engaging session. So we are moving on to the next session of our day. We are now moving to the muscle and nerve disorders. So for this session, I would like to welcome on stage Dr. K.S. Anand, Professor and HOD of Neurology from RML Hospitals, Dr. Anil Mota, Senior Consultant Internal Medicine from Max Hospitals, Patparganj, and Dr. Kurian Thomas, Consultant Neurologist, Indo-American Hospitals, Kottayam. Sir, please take the stage. I would request our esteemed speakers to please introduce our first speaker, Dr. Madhusudanan, sir.
Good afternoon. Dr. Madhusudanan is one person who needs no introduction in neurology circles. So I will not delay him from his presentation today. He is known as the teacher of teachers among neurologists. He is one of the most senior respected neurologists in our country. And I am sure it is going to be a very informative and beneficial session for all of you. So, sir.
So thank you, Chairpersons. At the outset, I would like to thank the organizers, especially Dr. Arun Garg, for inviting me to be part of this program. So what I am going to do today is a brief approach to the problem of acute neuromuscular weakness, which means that there is rapid onset of muscle weakness progressing within a period of, say, less than 4 weeks. If a person comes to you with an acute weakness of short duration, just like any motor weakness, the first aim is to differentiate whether the weakness is due to element weakness or a human weakness. For element, all practical purposes, includes neuromuscular junction and muscle disease because they behave similarly in a clinical fashion. But many differentiating points are not applicable in the acute clinical setting. For example, muscle tone and wasting. So human weakness tone will not develop and become spastic acutely. In element weakness, it will take time for the wasting to appear. Sometimes it's very difficult to differentiate LM from human weakness. Let us see this story of a 14-year-old boy. He came with this difficulty in walking, difficulty in getting up from squatting position over the last 1 week. No pain and paresthesia. Sorry. Will you play that? Okay, right. Okay.
Maximum
Here, normal power of the upper limbs, both proximal and distal. The lower limb knee extensions were weak. Flexors of the ankle were also weak. And looking at the reflexes, upper limb reflexes were all normal. Abdominal reflex was intact, there was no behavior sign. Lower limb reflex were quite brisk, both knee and ankle jerk. And plantar was indefinite. We have some suspicion of plantar upgoing on the left side. There is some suspicion, not very definite. Sensations were all normal. And this is the gait of the patient. He has got waddling gait. He's also got difficulty in standing on heel, but not on toes. Now, what do you think is the likely diagnosis? The patient was treated and his weakness totally improved in 2 weeks' time. See the follow-up video. His waddling disappeared, so also the distal muscle power has come back. Now, what do you think the patient might have had? Is it element weakness or human weakness? We do not know. What test was done in this patient is when electrophysiology, NCV was done, showed low EMF amplitude for all the muscles in the lower limb, but upper limbs were normal. snaps are all normal. FF latency is also normal. So what do you think is the likely diagnosis? Is AADP? No, because there is no prolongation of distal latency, decrease in the contraction velocity, or prolongation of FAF. It is something like a contraction block distally or an axonopathy, but he improved in 2 weeks' time. So what we are dealing with is a nodopathy or a man with reversible contraction block. So this is to show that it's not that easy all the time. You can have element weakness with brisk reflex. Now, on the contrary, the human weakness can also mimic element paralysis, or as you know, the spinal shock. And it may last for up to 1 to 2 weeks or even sometimes longer. The human weakness can be sometimes masked by the presence of associated neuropathy or a radiculopathy, as in the case of diabetic peripheral neuropathy patient developing a myelopathy. So in such situations, certain clues can help. For example, in this boy, the clue for doing the electrophysiology was that his proximal muscles are more affected than the distal muscle. So what are the findings in a person coming with a short duration acute neuromuscular weakness? What are the findings which strongly suggest a myelopathy or exclude a myelopathy? The strongly suggesting are sensory level on the trunk, suspended band of sensory loss, that is a band of spinothalamic sensory loss, spinal tract crossed findings, unilateral pyramidal signs with the contralateral spinothalamic findings, spinal tract specific sensory findings like selective spinothalamic findings with preserved posterior column, and root plus long tract signs, Hermit signs, and cradle. They may present, you can think, relatively more likely to be a strongly caught lesion. There are certain signs which are consistent but not diagnostic. For example, glow and stalking sensory loss can occur with myelopathy, but always it's a feature of peripheral neuropathy. Ascending sensory loss can occur not only in myelopathy but also in AADP and CIDP. And paraparesis without sensory signs, symptoms, do not forget to rule out a parasagittal lesion. Now, today, in my talk today, I will confine myself to the element type of neuromuscular weakness, and what is the clinical approach is just like any other neurological problem, site of lesion, likely pathology, and etiology. As you know, the site of lesion may be in the anterior horn cell, so-called motor neuronopathy, radiculopathy or polyradiculopathy, plexopathy, peripheral neuropathy, that means maybe single nerve, multiple nerve, or a diffuse symmetrical involvement, radicular neuropathy, neuromuscular junction, and muscle disease. Our task is to differentiate where exactly is the site of lesion. So for localization, we have to know what systems are affected, motor, sensory, autonomic, or mixed. For clinical purpose, you can divide them into two. This is my own approach. This may not be palatable to all, but this is how I proceed. I divide them into two categories, one with sensory affection, one without sensory affection. If we find that sensory system is also affected, that excludes anterior horn cells, neuromuscular junction disease, and muscle disease. If sensory is affected, that favors a radiculopathy, neuropathy, or radicular neuropathy. But that does not mean that, for example, if sensory is not affected, that does not rule out radiculopathy or neuropathy in toto. For example, if all peripheral nerves are not motor sensory, there can be a certain long thoracic nerve or a deep branch of one, and it can be purely motor. And some pathologies may selectively affect the motor component of the peripheral nerve, for example, MMCB, as you know. Similarly, sensory may be totally spared in radiculopathy since motor and sensory radicals are separate. And this is more likely to occur in lumbar cyclic roots, where the motor radicals got alone may be affected because of the long course in the spinal theca. For example, a neurofibroma in the cauda equina may mimic a motor neuron disease, progressive muscular atrophy. Now let us approach both case scenarios. One is with motor sensory affection and without sensory affection. Let us localize the lesion. Lesion may be in the roots, plexus, and nerves. And where is the affection is determined by the distribution of the muscle weakness and the sensory loss, as you all know. For example, radiculopathy, motor weakness, and myotomal distribution, sensory loss, the dermatomal distribution. Neuropathy, it is in the nerve distribution. And plexus, depending upon the site of plexus. There are other certain features can help to localize to the radiculopathy. For example, presence of root pain, paraspinal muscle spasm. And two, three points is that Neurogenic atrophy in a root lesion is mild compared to the nerve lesion. Monoradiculopathy seldom causes marked weakness of a single muscle or a muscle group. Somebody comes to with a foot drop, zero power, it is unlikely to be an alpha radiculopathy because one muscle is supported by more than one root. Then monoradiculopathy is not associated with autonomic involvement. Now, for localized radiculopathy, you should know the segment pointing muscles. I will skip that thing. That is, for example, if EHL is weak, you know that's a sign common of alpha radiculopathy. If C5 root is affected, the rhomboid should invariably affected. So such segment point muscles you should remember to localize to a root lesion. Come to the nerve lesions, I already told you the distribution is in the nerve distribution. But certain pitfalls you should be aware again. For example, in early ulnar lesion, the first muscle affected is in the adductor of the little finger. So the early sign may be the so-called Waterberg sign. When you put your hand in the pocket, the little finger will jut out. And in common peroneal palsy due to lesion in the fibula head, even the peroneal muscle may be spared. So in sciatic nerve affected proximally, hamstrings can be spared. Anti-introversus nerve involvement, the only muscle affected may be flexor pollicis longus. So these pitfalls you should be aware in diagnosing a nerve lesion. Plexus lesion, it does not respect a root or nerve, but certain clues can help. There is no root pain, no paraspinal muscle spasm. The trunk lesion, the weakness is the distribution of the roots, which form the trunk minus those directly arising from the root. For example, if a lesion is in the upper trunk of the brachial plexus, that conform to the supply of C5, C6 roots, but minus the one, that is the dorsal scapular nerve, which arises directly from the root. Cord lesion does not respect a root or trunk. It is in the distribution of the multiple nerves which arise from the cord. Now, radicular neuropathy, this term conventionally has been given for a patient with bilateral affection of proximal and distal muscles which is sensory loss. But this is a very confusing term, I tell you, because clinically it will be very difficult to differentiate this from a diffuse polyneuropathy where proximal nerves are also affected. So it's essentially not a clinical term. So I will first confine myself to diffuse PNS affection, leaving aside monoradiculopathy or plexopathy, etc. So it may be diffuse affection with sensory motor is polyneuropathy, polyradiculopathy, or polyradicular neuropathy. To localize, the first step is to find out whether affection is a length-dependent one or a non-length dependent one. You know what is length-dependent and non-length dependent. In the length-dependent peripheral neuropathies are distal symmetric peripheral neuropathy. Non-length dependent neuropathies include multifocal neuropathies, modern trace multiplex, polyradiculopathies, and polyradicular neuropathies. Now coming to the second part is the etiology. To find we are localized, and the second is the etiology of the lesion. To find out the cause of polyneuropathy, we would like to know the likely pathology of the nerve affection, whether it's axonal or demyelinating. This gives a clue to the likely etiology. So differentiation between axonopathy and demyelination is based largely electrophysiological. However, certain clinical points can help because axonal, you diagnose wasting indicates axonal affection. Poor demyelination will not produce wasting. Presence of fasciculation and DTR tend to be preserved unless there is a significant weakness. As told last time, more than 50 to 80% of the fibers has to be lost to produce clinically significant weakness if the axons are lost. But on the contrary, in demyelination, there is early areflexia, and also, as you know, there is no wasting of the muscles. But remember that a partial demyelinating lesion will not produce clinical weakness unless there is a conduction block. Now coming to the various causes or the multifocal motor neuropathy. Commonly, this results from disorders that infarct, inflame, or infiltrate the nerves or render them more susceptible to compression. It can be axonal and demyelinating. Axonal, most of the causes are axonal, some are demyelinating. The causes may be ischemic, like vasculitis, diabetes mellitus, cryoglobulinemia, or inflammatory. Some of them are demyelinating, like multifocal motor neuropathy or MADSM, or acute brachial plexopathy, which is axonal. Then can be infective causes, as you all know, HIV, Hansen disease, inflammatory conditions, and hereditary causes like HNPP. Now coming to polyradiculopathies, They are disorders, they affect multiple roots, as the name suggests. They have got the segmental pattern of deficits, and this site of lesions has got a high probability of cranial nerve involvement than the multifocal mononeuropathies. And polyradiculopathies may also result from disorders that infarct and inflame the meninges, infiltrate and inflame the meninges, and the nerve roots and cranial nerves are that traverse them. The cause can be infectious like CME, Lyme's, HIV, TBM, inflammatory like sarcoid, neoplastic like leukemia, lymphoma, melanoma. Now coming to polyradicular neuropathies are the commonest variety which you all come across, that GBs and its variants, ADP, AMAN, AMSAN, Miller-Fisher syndrome. And there's a tremendous overlap between the Bickerstaff encephalitis, Miller-Fisher syndrome, and the Guillain-Barré syndrome. The signs can occur jointly, can be vary from one to another. The infective causes of polyradicular neuropathies are CME and Lyme's disease, hereditary porphyria, toxic conditions like arsenic, N-hexane, amiodarone, diphtheria, metabolic, diabetic neuropathy, idiopathic neurologic hematopathy. Now, coming to length-dependent peripheral neuropathy is the classical peripheral neuropathy that they are distal more affected than the proximal. So-called stocking glove and pattern. By the time sensory impairment spreads to the knee, upper limb should be involved, and the sensory loss is graded, by which means the distal part is more affected than proximally. Similarly, motor affection is there. The distal muscle will be affected more than the proximal muscles. First affection will be the intrinsic muscles of the feet. That is the thing which occur in neuropathy. On the other hand, distal myopathy spare the distalmost muscles like small muscles. Just like sensory, by the time motor weakness affects the knee muscles, upper limb muscles should have been affected. Now the causes most of the causes are length-dependent axonopathies, but demyelinating pathology can also occur as in DATS variety, that is the acquired demyelinating length-dependent neuropathy. There's only demyelinating type. Some of them can be associated with IgM monoclonal antibodies, especially anti-MAG antibody. The infectious causes of neuropathy like diphtheria, borreliosis, rabies, CME, Epstein-Barr virus, hepatitis B, AIDS and vaccination. Metabolic are the most common cause like diabetes, porphyria, beriberi. Toxic neuropathies, drugs, chemicals, lead, arsenic, organophosphates, chemotherapeutic agents, alcoholic neuropathy. This all here today morning itself. So many causes of drugs and toxins which can neuropathy. Now, vascular neuropathy classically produces mononeuritis multiplex, but however, this kind of length-dependent pattern also can occur in vascular neuropathy, especially in Sjogren syndrome and critical illness polyneuropathy. Now I come to the second part of the talk, that is acute neuromuscular weakness without sensory affection. The site may be antitonsil, manual junction disease, and muscle disease, as you know. The caveat is that some of the radiculopathies and polyneuropathies can present only with motor. So we include pure motor neuropathies as well. So antitonsil disease typically presents progressive painless with associated cramping and fasciculation. When to suspect? Pure motor affection, patchy affection of the muscles, fasciculations, and marked atrophy. But these two may not be there in the acute clinical setting. Pitfall I already told. Neuromuscular junction disease, when to suspect? The muscle weakness do not respect any nerve or a root pattern. For example, if somebody comes with medial and lateral rectus that is not forming a nerve pattern, think of that thing. Jaw opening is strong, but jaw closure is weak, such thing that some of the muscles in the single nerve is affected differently. No wasting, no fatigue, and presence of fatigability and episodicity, and significant weakness with normal reflex features of minor junction disease. And there are certain signs in the oculum I will skip. Muscle disease, when to suspect, that does not respect any nerve or root pattern. Bilateral symmetrical affection, but asymmetric can occur in certain myopathies like FSHD. And affection of only one limb almost never occurs in myopathy. And proximal muscles are more affected than distal. Pain in the muscles can also be seen in the acute radical neuropathy and plexopathies. Coming to the etiology, I will skip antitonsil. These are the causes of infections. Poor motor neuropathies like AMAN and acute motor ADP, critical neuropathy, and toxic neuropathy. I think I will stop here. neuromuscular causes, and muscle disease can be these are the acute neuromuscular muscle diseases. So thank you for it. In conclusion, by methodical clinical approach, we can localize where the lesion the PNS, but finding the etiology requires further investigations. Thank you for your patient listening.
Thank you, Dr. Madhusudanan. It was a wonderful, talk about the sensory and the non-sensory approach to acute neuromuscular weakness, peripheral. So thanks for that. I think I will now request Dr. S.V. Khadilkar to talk about the clinical spectrum of chronic immune-mediated demyelinating polyneuropathy, which is a common trouble that most of us encounter while we are sitting in the ICUs. And then finally, we have to request our neurology friends to please bail us out. So we request Dr. S.V. Khadilkar to talk about it. Thank you.
The timer just shows 18 minutes. 25, okay. Right. Okay. So, good afternoon, everyone. And firstly, let me thank Dr. Garg for asking me to be here. It's a privilege and a pleasure. It's also a pleasure to speak after Dr. Madhusudanan, whom you all know is such a erudite lecturer. So, I'm going to take you through what I have called Beyond CIDP, where we'll go over some of the forms that you don't so often see. I may fall a little short in time, but then I'll stop when the time is over. Right. So the spectrum of chronic dysimmune neuropathies has widened well beyond CIDP, and various variants have been recognized in the last few years. And differentiating them is important because, firstly, for diagnosis, secondly, for appropriate therapy, and thirdly, for prognostication. So what is typical CIDP? Chronic and often fluctuating course, usually sensory motor and symmetrical, but can also be a little asymmetrical or focal. And the conduction velocities are slowed. There are conduction blocks and temporal dispersion, and variety of criteria are used for the diagnosis. They generally respond to corticosteroids and or IVIG, and they can be secondary to some of the diseases that we know. Which are the atypical ones? The pure motor one, like Dr. Madhusudanan alluded to, the MMN with conduction blocks or without conduction blocks. The MAD-SAM, the DADS, the acute onset CIDP. Then there are the infrequent forms, only proximal ones, CISP, which can be pure motor or pure sensory, focal forms, and hypertrophic mononeuropathies. So you could divide the dysimmune neuropathies into acute, subacute, chronic, various ways of dividing them, like GBS, SIDP, CIDP, or sensory motor autonomic, DADS, MMN, CB, GBS as examples, or depending on whether they are proximal or distal or ganglionic. So CISP, CIMP, CISMP as proximal forms, DADS as the very distal form, and Sjogren's syndrome as the ganglionic form. So I'll illustrate some case studies. I'll go rapidly. If there are any questions, we'll take it in the end. This 52-year-old chartered accountant was seen in 1990 initially, when I just started practice, with right hand tremulousness and weakness. In 1992, he had tremors and weakness of the left hand. Examination showed thickened nerves, asymmetrical upper limb weakness, mild sensory decrease distally. His tendon reflexes were for some reason initially present. These are Professor Wadia's notes about him, which I show because I learned with him, and I was always amazed as to how he could give notes to everyone who came to him. Right, so the CSF protein was 1 gram. Electrophysiology showed multifocal conduction blocks at non-entrapment sites. The nerves were thickened, and he was put on steroids. He improved a little bit, but during this time, hands got wasted. 1996, he stopped writing. The sensations were reduced further, and electrophysiology continued to show multifocal demyelination. Please don't ask me why his reflexes were present for this presentation, because I want to save time. That's a class by itself. Right. So 95, 96, he started getting lower limb problem, slipping of the footwear without awareness. And 1999, 2000, the legs became very weak. He also had ankle fracture and his mobility went away. Started using special shoes. So ups and downs, but deteriorating course. Proximal leg weakness. Oral steroids restarted, helped him. But then he was catheterized. And he had pains in the lower back, radiating to both legs. This time I admitted him again. What's happening? Why the urinary catheter? Why the lower back pain? And I tried a CSF and I got a dry tap. By that time, we had newly got the MR neurography. So this was one of my first few patients on whom the hospital tried the MR neurography, and you can see how thick the sciatic nerves are. They're literally like elephant's trunk. So I'm showing you a case of Mad Sam variety of what some people call hypertrophic neuropathy. Started in one hand, then the other hand, then the legs, slow progress, ups and downs, high CSF protein, conduction blocks, response to steroids. But this question, why urinary symptoms? And this is what his MRI showed. Look at the lower part. The nerve roots have become so thick that they themselves have become an obstruction to them. So where the arrow points, you can see that there is no subarachnoid space anymore. So an occasional Mad Sam, the roots can be so thick that they throttle themselves. This is a rare example. Of course, there are examples like this in literature. And I had another patient who came as a lumbar canal stenosis, but actually had a CIDP. So that's Mad Sam, the Lewis-Sumner syndrome. Striking multifocal presentation, slowly progressive demyelinating neuropathy, upper limbs more than lower limbs, proximal as well as distal, more common in females, 40 years being the median age. CSF protein is elevated a lot. Some people have antibodies to IgM, and asymmetry, focality, really separates it from others. Sensory separates it from multifocal motor neuropathy. SNAPs are usually low, and the biopsies show D and remyelination. And this is one such patient where you see the onion bulb appearance. And a similar finding you'll get in inherited neuropathies as well. So that just shows D and remyelination. And they respond to steroids. That's very important. They respond to steroid just like CIDP responds, and to IVIG as well. So we have seen Mad Sam. Now we'll see a 26-year-old male, symptomatic since 2017. Started with the weakness of the right hand. He was actually sent to me with two differential diagnoses, Hirayama disease and young onset anterior horn cell disease, and he was extremely worried. But in view of time, I'll cut the story short, and I'll show you that he basically had a wrist drop. It was pure motor. His electrophysiology showed conduction blocks in the radial nerve. And this patient had a thickening on the MRI of the radial nerve going up to the radial groove. Pure motor, young male, wrist drop, conduction block. This is multifocal motor neuropathy. And this patient, after treatment, I mean, he's been with me for now 3.5 to 4 years. And he responds to IVIG periodically. So this is how he is now. He's not normal, but he's much better. And this patient, I like to show this patient keeps his charts as to how he improves along with his physiotherapist. How different muscles improve in relation to IVIG. And it's beautiful to see that he takes IVIG and he becomes better. In fact, he's come to a point where he phones and tells me, "Doctor, my next IVIG is due because I've started getting weaker again." And from a point where he thought he has had MND and he's going to die, he's sort of become a chartered accountant, he's married, and he sort of leads a decent, good quality life. The charts, again, we can't go into details, but make another point that some muscles improve better than the others. So when you say MMN responds to IVIG, it's not that everything will respond with the same magnitude, different in different magnitudes. So unless you're doing a good muscle charting, you wouldn't know how the response is going. So that is MMN. MADSAM was more common in females, MMN is more common in males. MMN is a little younger individuals as well, and a radial, a wrist drop and a finger drop. Yesterday itself I saw one other patient whom I think is MMN. It's a steady progression or stepwise deterioration. Two progressions are known, and uncommonly they come with an acute wrist drop. I haven't seen any such patient. Spontaneous remissions are known, but they respond only to IVIG. They do not respond to steroids. Like MADSAM will do well with steroids. These patients will not. Now, I do not know why. There is MR neurography experience on this showing thickening, and biopsy again shows various things. Again, for want of time, we will move over. We saw MADSAM, then we saw MMN. One is sensory motor response to steroids, second is pure motor, younger age, males, wrist drop, and responds only to IVIG. This is a 64-year-old man, asymmetric sensory motor neuropathy with distal involvement, electrophysiology showing widespread multifocal, motor more than sensory, upper limb more than lower limb, demyelinating polyneuropathy, and serum protein electrophoresis showing an M band, which is not in the range of myeloma, but in the range of MGUS. So this is MGUS, monoclonal gammopathy of unknown significance. And this particular patient I've been tracking for almost 15 years now. He hasn't turned into a myeloma. And he is another person who's responsive to IVIG and continues to do well. Of course, God has been kind to him, so for 15 years he's taking IVIG every few months. So that's MGUS. Then there is DAD, that again Dr. Madhusudanan alluded to. It's a distal neuropathy, sensory neuropathy. It's a symmetrical, exclusively distal sensory neuropathy. And you wish that you don't get such a patient because their sensory symptoms just don't respond to anything that you do. Right. Now, I'll take you through again another case of sensory ataxia. This is the summary of the case: hypothyroidism and hypertension. Came to me with sensory ataxia of 3 years duration. Joint position lost at toes, vibration lost till anterior superior iliac spine, very minimal weakness of dorsiflexus and iliopsoas, absent tendon reflexes, and Romberg strongly positive. So sensory ataxia with little weakness for evaluation. So where is the localization of this large fiber sensory loss? It could be any of the ones mentioned in this slide. Right. I thought electrophysiology will give the answer, but the standard EMG nerve conduction study came normal. But his SSEPs were abnormal from the lower limbs. They were normal from the upper limbs. And this is again one of our early patients with MR neurography, showed thickening of the roots. You can see the S1 roots being thickened. So this is a sensory ataxia with areflexia, with normal distal conductions, and proximal MRI showing thickening. Normal lumbosacral spine MRI, neurography showing thickening, distal segment normal. So with a albuminocytological dissociation. So SSEP is abnormal, nerve roots thickened, nothing else wrong. So this is the isolated proximal form of the CIDP spectrum, which is called CISP. Chronic immune sensory radiculopathy. There is no neuropathy. So if you give your technician a study to do, he'll come back saying everything is normal, unless you are at it where the diagnosis is. So a few words about chronic immune radiculopathies. There are now 3 forms identified. There are actually 4 forms identified. CISP was the first one, where only sensory ataxia and proximal. Then CIMP was the second one, where only motor and very few cases are on record. They look like ALS. And CISMP, initially we put it in literature with 2 patients, and then Bashar Katirji's group put 9 patients, and now there's a 4th form called CISP plus, which is not on these slides, which is put up by James Peter Dyke and his group. So these cases have been around. I don't think they are too uncommon, but they skip our attention because we don't study the proximal segment all the time. So when you have a sensory ataxia or a motor weakness for which no easy explanation is coming, take help of MRI neurography. And these are some of the papers that we had put up in this segment. Recently we put up a paper in Muscular to say that all these 3 forms are mixed. They're not separate forms. CISP also has a little motor, CIMP also has a little sensory. But so we sort of said that this is how they should be named: CISMP, CIS, small mp, and reverse, depending on which component is more. But some groups do not agree with that. Right, so pure proximal forms. Then I'll show you a patient with a progressive flail arm. A patient with a progressive flail arm with CSF protein showing slightly elevated and a multifocal demyelinating plexopathy. And this is his MRI. This patient's history was very long, and I thought nothing will touch him. It was in several years, but with the first IVIG he improved. So I have no idea what goes on pathophysiologically, what changes after so many years. But even if you see a long history, don't get too worried. This is another patient with a demyelinating focal plexopathy. Then this is a boy who started at GBS and then went on having events again and again. When he had them again and again, then we started wondering what is happening here. And to cut a long story short, he also had thickening of the nerves, and steroids helped him a little, IVIG helped him a little, plasma exchange helped him a little. He was not doing well at all. So at that stage we decided to admit him and study him, and we sent the new CIDP nodopathy antibodies to Angela Vincent, which turned negative. And this is how bad the boy was, could hardly move. And rituximab helped him. So this is a young boy with what looked like a GBS, which is actually a CIDP, turned into a CIDP, antibody negative, but responded to rituximab. So just to stress that MR neurography is one of the tools that is gaining more and more in diagnostic armamentarium. And now our radiologist is confident enough to say inherited versus acquired by the characteristics that they see here. Like they have put it up in some paper. Right. Then the smallest unit of this is a mononeuropathy, a demyelinating mononeuropathy, which could be sciatic, which could be radial, which could be median, which could be any. These are generally in case reports in the literature. They respond to corticosteroids, but I don't think anyone has gotten them together to make a composite picture of what they are. And here are some of our patients who have shown single thickened nerve and have responded to steroids. Sciatic is particularly common in that. I don't know why. Right. So we've looked at various forms of the CIDP spectrum beyond the typical CIDP very briefly, but we touched upon the MADSAM, we touched upon MMN, we looked at MGUS, the DADS, then we saw the 3 proximal forms, CIMP, CISMP, CISP. Then we saw the focal forms, brachial plexopathy, we saw mononeuropathy, and we touched upon an ACIDP presentation of neuropathy. So, couple of slides more. What are the really differences in a typical CIDP and an atypical CIDP? Typical CIDP is symmetrical or largely symmetrical, sensory motor, weeks to months story, usually get diagnosed pretty quickly. NCS are always abnormal. SSCPs are not always required in the diagnosis. MRI study is not always needed, and prognosis is fair. Atypical CIDP is often very asymmetrical or focal. It may be pure sensory or it may be pure motor. The story may be very long, going into months to years. The time to diagnosis, because it is atypical, is usually long. NCS dystally may be normal in some focal forms which are proximal, which is a very important point to remember. You need SSCP in these patients. MRI study is gaining more ground in diagnosing atypical neuropathies, and the prognosis one doesn't know. DADS doesn't improve that well, MMN doesn't improve that well. So these forms, some of these forms are difficult. So in general, the forms beyond CIDP are underdiagnosed. They have various variable clinical features, but they are treatable. Therefore, important to pick them up. The key tests are detailed electrodiagnostic study, including SSCP, MR neurography, CSF, the newer antibodies, and sometimes a biopsy or genetic studies. And all this is relevant because obviously there are different mechanisms doing these different things within the spectrum of immune demyelinating radiculoneuropathies. And if we understand them better, someday we will put together the picture better. Thank you very much.
Thank you, sir. The session was very informative. I'm sure that all of you benefited. There are a few people in the country who can speak with so much wealth of experience on such a difficult topic, having managed the cases over years. Thank you, sir. The session is open for questions if any of you have any doubts.
Hello. Sir, Khadilkar sir, wonderful presentation. I have a question to you.
Ask a simple one, man.
The wonderful presentations have made it so simple. Sometimes the Lewis seminar worsens with steroids. You have seen that a few patients of Lewis seminar can worsen when you start steroids. So I had a patient, we told 100% you will improve because previously we had all good improvement with steroids with Lewis seminar. We started steroids and he worsened. So in such patients, you give IVIG or you have experience with that?
I mean, our general approach has been to use IVIG or plasma exchange in them. IVIG more often than plasma exchange because of this. But some of the difficult ones are going on to rituximab as well. I mean, even rituximab, like everywhere else, is all of us are finding it easier to use. And but you're right, there are some patients of asymmetric CIDP who don't do well with steroids.
Thank you, sir.
Sir, I have a question. In pediatric population, invariably after a simple viral ailment, the children would present to us with proximal weakness, waddling gait, and acute onset weakness. And this typically happens when the fever settles down. In convalescence, they come with a lot of weakness. Then they settle down with simple rest and nutritional support. But this tends to recur again and again. So I think you must have encountered this. What is the final outcome and how do they progress in future?
I mean, there are these kids who get weak in response to an infectious illness and then they become better, and again when they get it, they again become weak. I must say that my diagnostic yield in this category has been very poor. Some I have chased completely with genetic reports and muscle biopsies and metabolic profiles. I don't know what they are. There's some kind of minor metabolic defects which may have a genetic origin. They're definitely there. Such kids are definitely there. They are brought to you from time to time. Some of them get better as the age goes on. Some of them get worse as their age goes on. So I actually I do not have an answer to your question other than saying that these patients are definitely there. They behave like this as a broad pattern, and in a majority I haven't found anything, even those whom I could chase completely.
Sir, can I request? I have one.
Yes.
I have one query, sir.
Yes, please.
With all the beautiful presentation that you showed, can we take home message that rituximab is the drug of future and we can do away with IVIG?
No, I don't think so. I think you asked a very, very relevant question. I think the paradigm still goes convention, but one doesn't stop when these things don't work. One thinks of rituximab. Now, if you look at a drug's life history, it comes in as a drug for difficult cases. The drug comes when nothing is working, you use it. And then it starts coming earlier and earlier, and then you start using it earlier. So there is a good possibility that the same may happen with rituximab. But then we have to also keep in mind that it's an off-label drug for some diseases. And before you use it, you should have exhausted the conventional ones. So maybe 5 to 10 years from now, we may be seeing much more rituximab than today. But I think today, at least in my practice, I keep it for situations that are not easily coming under control.
Thank you, sir. I think if there are no further questions, we can proceed ahead. Thanks a lot.